Hello and welcome, everyone. Thank you for joining us for Convergent Procedure for Atrial Fibrillation. Our presenters tonight are Dr. Nikhil Warrier, cardiac electrophysiologist, and Dr. Tuan Lam, cardiothoracic surgeon. Our first presenter today is Dr. Nikhil Warrier.
Hi, I'm Dr. Nikhil Warrier. I'm a cardiac electrophysiologist at Orange Coast Medical Center. So we're going to be talking a little bit about atrial fibrillation and why convergent ablation may be a good strategy. But before we get into kind of what the procedure entails, it's very important to understand what atrial fibrillation or AFib is. So AFib or atrial fibrillation is an abnormal heart rhythm disorder or arrhythmia when the heart doesn't beat in a regular or steady pattern. It is the most common type of heart rhythm disorder. It accounts for a significant majority of my clinical practice on a day-to-day basis. In atrial fibrillation or AFib, the heart's upper chambers, the atria, they fibrillate or quiver, which causes a rapid, irregular heart rhythm. The atria can beat anywhere between 300 to 600 beats per minute. Next slide, please. Some of the risk factors for developing AFib include age, high blood pressure, which accounts for about 20% of cases, family history of AFib, obesity, smoking, heavy alcohol or caffeine intake. We see this pretty significantly, especially after the New Year's Eve parties with patients who come in with holiday heart and rapid atrial fibrillation, stress due to surgery or other illness, diabetes, and structural heart disease, whether it's ischemic or valvular heart disease. Next slide, please. Estimates of the prevalence of AFib in the United States range from about 2.7 million to 6.1 million. According to the CDC, approximately 2% of people younger than 65 years old have AFib, while about 9% of people 65 years and older have it. At the age of 80 years, the lifetime risk of developing AFib is quite substantial with a rate of approximately 22%. And as our population ages globally, AFib is predicted to affect 6 to 12 million people in the United States by the year 2050. Next slide, please. So some of the common symptoms that I hear complaints from most of my patients include fatigue, rapid irregular heartbeats or palpitations, fluttering or thumping in the chest, shortness of breath, weakness, lightheadedness or dizziness, faintness or confusion, and chest pain. The most common symptom is fatigue. And it can be the hardest symptom to kind of tease out when it comes to patients trying to figure out what the cause of the fatigue is. And that may be the one that it may take a long time before you end up seeing a cardiologist for evaluation. Next slide, please. So in terms of definitions of AFib, it's classified into 4 different forms. Paroxysmal is the easiest one to handle, and we define paroxysmal atrial fibrillation as having patients in whom the heart returns to a normal rhythm on its own without any intervention within 7 days of its start. Episodes in this patients may occur only a few times a year, or their symptoms may occur every day and can be very unpredictable. Patients with persistent atrial fibrillation have arrhythmia lasting longer than 7 days. And in these patients, restoration of normal rhythm will require some form of treatment, either a cardioversion or an ablation. Long-standing persistent atrial fibrillation is those patients who have the irregular rhythm lasting longer than 12 months. And permanent AFib is considered in patients who have AFib and the doctor and the patient have decided together to not continue any further attempts at rhythm control. Next slide, please. So how do we diagnose AFib? So we use rhythm monitoring devices to diagnose and detect atrial fibrillation. The most common form that everybody has some experience with is an electrocardiogram. You go to the doctor's office, get a 12-lead electrocardiogram, and identifies what type of arrhythmia you're having. The problem with that type of diagnostic tool is that you have to be in the arrhythmia for us to find AFib. So in patients who are normal rhythm on that initial 12-lead EKG and we suspect atrial fibrillation, Holter monitors are helpful, or longer-term ambulatory monitoring such as MCOTs. In patients with infrequent episodes or those who have had a stroke and need long-term monitoring for subclinical atrial fibrillation, we do implant a loop recorder, which is a small, probably 2-3 inch device in terms of the length that we implant that can last up to 3 years. Additional investigations that we perform are an echocardiogram to rule out structural heart disease, as well as an exercise or pharmacological stress test. Sleep studies also oftentimes obtained to rule out sleep apnea, and thyroid function tests are very important to rule out a hyperthyroid state. Next slide, please. So, this is kind of the most important slide of the entire slide deck, and it's the third line on this slide that's really important, which is atrial fibrillation or AFib needs to be treated whether or not you're having symptoms. And the reason we're very, very the emphasis on that is because of the increased risk of stroke and heart failure. And the increased risk is almost fivefold. Next slide, please. So what is the relationship between stroke and atrial fibrillation? So we know that ischemic stroke is among the leading causes of death and disability in the United States and world. AFib is a well-recognized cause of ischemic stroke. Fortunately, the risk of stroke in the presence of atrial fibrillation can be reduced by over 70% with systemic anticoagulation. Given the often paroxysmal and asymptomatic nature of atrial fibrillation, however, it may not be detected with the use of traditional monitoring techniques. And this is why in some of the patients who have subclinical AF and stroke as a presenting manifestation of AFib, we do recommend a long-term monitor, such an implantable loop recorder. Next slide, please. So the rationale for that is can be summed up by this study by Brambati and colleagues who undertook the ASSERT study, which was published in Circulation in 2014. This was a prospective observational study that followed almost 2,500 patients with pacemakers or defibrillators. Inclusion criteria included patients greater than 65 years old with a history of hypertension, but no history of atrial fibrillation. And the purpose of the study was to identify the temporal relationship between subclinical AFib of greater than 6 minutes in duration with stroke. Of 51 patients with stroke during the follow-up, almost half demonstrated subclinical AFib, 26 patients. In 18 patients, subclinical AFib was detected before the onset of stroke. Only 4 patients demonstrated subclinical AFib within 30 days of the stroke. In 14 patients whose most recent episode of subclinical AFib before the stroke occurred more than 30 days before the event, and the median duration between the event of stroke and the most recent episode of AFib was 340 days, so almost a year. Next slide, please. So, in terms of mechanism, so this underscores the two kind of mechanisms of AFib that we identify in most of these patients. One, it's a very familiar, which is in AFib, there's mechanical standstill of the atrium, which results in intraatrial stasis and thrombus formation. The other mechanism, the one that the data in the ASSERT trial suggests, is that AFib and stroke are two separate manifestations of an atrial myopathy or disease, in which there is decreased atrial mechanical function, even in normal rhythm. So the stroke risk is not related to the timing of the AFib or the duration of AFib, but related to other cardiovascular risk factors. And we use a clinical tool called CHADS-VASc for estimating the risk of stroke in patients with non-valvular AFib. Next slide, please. So these are the risk factors that we include in the CHADS-VASc tool. So you get a point for each of these risk factors. The C stands for congestive heart failure, H for hypertension, age, you get 1 point for age 65 and older, and you get 2 points for age 75 and older. Diabetes is the D. S stands for the stroke, and you get 2 points for having a prior stroke. Vascular disease history, whether it's peripheral or coronary artery disease, and you get an extra point for female gender. As you can see, with each additional incremental risk in terms of the risk score, the percentage of stroke risk increases pretty significantly. And when you get to CHADS-VASc of 9, your risk of having a stroke is about 15% per year. To minimize the risk of stroke, we use systemic anticoagulants. The mainstay of therapy used to be warfarin or Coumadin, which required frequent blood checks and had significant drug-drug interaction as well as dietary interaction. Now we use newer anticoagulants called direct oral anticoagulants or DOACs, such as Eliquis, Pradaxa, Edoxaban, and Xarelto or Rivaroxaban. Next slide, please. So what is the relationship between heart failure and AFib? We all know that heart failure and AFib frequently coexist. Up to 50% with a new diagnosis of heart failure have concomitant atrial fibrillation. And approximately 1/3 with new onset atrial fibrillation have congestive heart failure. Of course, the chicken or the egg, it's very difficult to discern, as heart failure through structural and ionic atrial remodeling increases the likelihood of atrial fibrillation. And atrial fibrillation itself can cause some degree of cardiomyopathy and contribute to impaired ventricular systolic function. It's been long understood that in patients with clinical heart failure from impaired LV systolic function, the presence of atrial fibrillation is associated with negative outcomes such as worsening heart failure, stroke, and death. Next slide, please. So, we've talked a little bit about what AFib is, why we care about AFib. So how do we manage treatment of AFib? And the most important thing to understand is that it's tailored to each individual patient and usually depends on how long the patients have had AFib, how bothersome the symptoms are, and the underlying cause of AFib. Generally, the overall goals are to address the risk of stroke, which is very, very important to prevent blood clots with blood thinners, to determine a rhythm or rate control strategy, which can be addressed with either medications or catheter ablation, and healthy lifestyle changes to manage AFib-related risk factors, which include screening at-risk patients for obstructive sleep apnea, and device-based therapies for patients with bradycardia and atrial fibrillation, or significant tachycardia as a blatant pace method. Next slide, please. So some of the invasive approaches we offer patients include catheter ablation in patients who have refractory atrial fibrillation despite medical therapy, or those who are intolerant of medical therapy. We offer left atrial appendage occlusion to patients who are high risk for bleeding and not a candidate for long-term anticoagulation. This device is with an occluder called Watchman. We also implant leadless pacemakers, such as the Micra, in patients who are in permanent atrial fibrillation with difficult to control rates as a part of an ablatant pace strategy, or in patients with persistent or permanent atrial fibrillation with significant bradycardia and for tachybrady syndrome. Next slide, please. So this slide is representative of our catheter ablation. The ablation procedure starts with access into the femoral veins. On the left side is us palpating the femoral veins. We do use an ultrasound to visualize the veins for our entry into the femoral vein. A representative slide is seen on the right. From there, an IV or sheath is introduced into the femoral vein, and instruments are advanced into the left atrium via transeptal puncture. This is performed under real-time intracardiac, fluoroscopic, and manometric guidance. Next slide, please. The next step involves voltage mapping of the patient's atrium with a high-resolution mapping catheter. This is akin to substrate mapping. This is one of my favorite parts of the case, partly because by the clinical information that we know ahead of time, we kind of have an idea of exactly what type of heart we're dealing with. But until we start doing substrate mapping, we really do not know exactly how to individualize our ablation approach to each patient. So as I mentioned, the ablation approach is individualized to each patient. The slide on the left is representative of a patient with paroxysmal atrial fibrillation, of relatively new onset. As you can see, the pink represents extremely healthy tissue. So the red dots are representative of our lesion set. So in this patient, we just did pulmonary vein isolation, and with a relatively healthy heart, the outcomes can be extremely favorable. On the right is a patient with long-standing persistent atrial fibrillation. And as you can see, that purple is replaced with yellows and red, which likely represent diseased and scarred tissue. To contrast, the right side, we ended up doing a little bit more in terms of the ablation with not just pulmonary vein isolation, but essentially isolating a lot of that diseased or healthy tissue with posterior wall isolation. Next slide, please. So why is a hybrid ablation recommended? So as we discussed, patients with long-standing persistent atrial fibrillation, long-term outcomes are less than ideal. This is just one slide from the Hamburg sequential ablation strategy study. It was a prospective study of 200 patients with long-standing persistent atrial fibrillation. All patients underwent PVI and additional cafe ablations if they were unable to cardiovert or had recurrence after pulmonary vein isolation. And during a 5-year follow-up, single and multiple ablation procedure success was 20 and 45%. So, outcome-wise, it's less than ideal, which is why we recommended hybrid ablation in some of these patients. Next slide, please. Next slide, please. So what type of patient may require hybrid ablation? So in standard non-persistent or paroxysmal patients, catheter ablation is first line. In persistent patients, especially those with long-standing persistent atrial fibrillation, hybrid ablation strategy performed with the cardiac surgeon as well as the electrophysiologist is certainly a very, very reasonable option. And those patients that are requiring any sort of cardiac surgery, the gold standard is Cox-Maze, and those patients are definitely candidates for surgical approach rather than a hybrid ablation strategy. Next slide, please. So how is a hybrid ablation performed? So the cardiac surgeon, again, Dr. Lam will speak a little bit more in detail about this, but the cardiac surgeon does the epicardial ablation initially. We stage these procedures to decrease the tissue edema that we can encounter immediately after the ablation. And then we bring the patients back for the endocardial ablation. We map the entire heart, including the posterior wall, and isolate all the things that were left from the initial ablation. So as you can see, the initial ablation is on the left, the upper slide. And when they brought the patient back for catheter ablation, we ended up touching up some of the work that was left over from the cardiac surgeon. And you get a nice outcome in terms of pretty significant PVI and posterior wall isolation on the right. Next slide, please. So some of the most important take-home points from my half of the talk. AFib is the most common type of heart rhythm disorder. Again, it needs to be treated whether or not you're having any symptoms. The treatment approach is individualized to each patient based on their risk factors for stroke and symptoms related to atrial fibrillation. And depending on type of atrial fibrillation, a hybrid ablation strategy may be the best chance for maintenance of a normal rhythm. And it's very, very important to see a heart rhythm specialist to discuss the best options for treatment of your heart rhythm disorder. And these are just some of the tools and resources. Thank you.
Thank you, Dr. Warrier. Our second presenter is cardiothoracic surgeon, Dr. Tuan Lam.
Hi, I'm Dr. Tuan Lam. So today I will talk about the treatment options for AFib. The options include catheter ablation, which is the least invasive and is a procedure performed by an electrophysiologist such as Dr. Warrier. The next treatment option is the surgical maze procedure, which is performed by a cardiac surgeon, and it is very invasive. The last option is a hybrid procedure called the convergent procedure. Part of the convergent is performed by a cardiac surgeon, and part of it is performed by an electrophysiologist. Next slide. So before we talk about the treatment options, I'd like to go over the electrical conduction system for the heart. Sometimes explaining the conduction system of the heart is not easy. So I came up with this analogy using the heart as a house. So imagine the heart has 4 rooms. There are 2 floors, the 2 rooms on the top floor and 2 rooms on the bottom floor. The 2 rooms on the top floor called the atrium, and then the room on the bottom floor is called the ventricle. So the way the conduction system works is there's a cluster of automatic cells in the top right chamber called the right atrium. These cells start automatically one electrical signal. That signal travels from the right atrium to the left atrium in less than a second, in a split second, such that as far as the eyes can see, the 2 atria contract almost at the same time. So after the 2 atria contract, the electrical signal travels to the 2 rooms on the bottom floor, the 2 ventricle. So the 2 ventricle contract almost at the same time, right? But you can see when you look at the heart that the 2 atrium contract before the 2 ventricle. The electrical signal is what causes the heart to pump, okay? So there's electrical signal and there's a mechanical activity. Mechanical activity is the actual pumping of the heart muscle. Next slide. So what happens in atrial fibrillation? So instead of having just one electrical signal that starts at the right atrium, in AFib, there are multiple signals that fire at the same time in both atria. So both the left and right, right and left atria have dozens and dozens of electrical signals that fire at the same time. So it's like fireworks in the top two chambers on July 4th. So the many electrical signals that fire at the same time give the appearance of the heart based that the quivering or fibrillating. Next paragraph. So what is catheter ablation? So catheter ablation is the least invasive and is performed by electrophysiologists. We call EP for short, EP. So the catheter is inserted through a vein in the groin called the femoral vein. The catheter goes up the femoral vein into the top two chambers of the heart, the left, in particular, the left atrium. So using the catheter, 4 ablation circles are created in the left atrium. These circles are where the origin of what's called the pulmonary veins. The 4 pulmonary veins drain blood from the lungs. How is the ablation performed? So the probe basically freezes the tissue around the origin of the pulmonary vein, and this procedure is easy to perform and is the least invasive. Next slide. Next slide. So as opposed to the catheter ablation, on the opposite extreme is the surgical maze procedure. This procedure is performed by a cardiac surgeon. It is open heart surgery and requires opening the chest and then stopping the heart and then putting the patient on the heart-lung machine. So as opposed to just the 4 ablation lines with the catheter ablation, the full maze procedure create at least a dozen ablation lines. They include the 4 ablation lines around the pulmonary veins, but include many other lines as well. The ablation can be done with a probe that freezes tissue on the heart, but can also be done with a clamp that delivers radio frequency ablation energy to create scar tissue on the heart. So the picture on the right shows all the ablation lines, and I realize it's hard to understand. So the next slide will show what these ablation lines are in the actual full maze procedure. Next slide. So on this slide, the picture on the right shows basically the 2 right atrium. The two right atrium have been put on a flat surface. So on your screen, the left side is the right atrium, and then the right side is the left atrium. The result of the full maze procedure is such that you create essentially a maze in both the left and right atrium, so that even though there are multiple signals that fire at the same time in both atria, there's only one pathway for the signal to travel from one corner of the right atrium to another corner in the left atrium. This procedure requires open heart surgery and is maximally invasive. Next slide. So a less invasive procedure is a hybrid approach called the convergent procedure. So one part of the convergent is performed by the cardiac surgeon and another part by EP. So the incision is about 1 inch. The incision is below the breastbone. This procedure does require general anesthesia, but does not require opening the chest. The next slide. So through the incision in the breastbone, there is a sheath demonstrated by the left upper picture. This sheath is placed through the incision into the sac covering the heart called the pericardium. And then through the sheath, a probe shown in the upper right picture. This probe is inserted through the sheath, and then the probe is connected to the machine on the bottom of your screen, and then the machine delivers a radio frequency ablation to create ablation lines on the back of the heart. Next program. So how is the conversion procedure performed? So the focus of the whole conversion procedure is on the left atrium. Okay, so not the right, but just the left atrium. So the probe is inserted through the sheath into the back of the left atrium, And then using radio frequency ablation, multiple parallel ablation lines are created in the back of the left atrium. After these ablation lines are created, the left atrial appendage, which is the site of the clot formation, which causes stroke, the left atrial appendage is clipped using a different incision. It's done through 3 small incisions on the left chest. The clipping of the appendage is done at the same time, at the same setting as the conversion procedure. And then the part that's done by EP are creating the ablation circles around the pulmonary veins that was described earlier. Next slide. So what are the risk benefits and then or the recovery? So the risk of the conversion is very low, and then the main concern is there may be unexpected bleeding that may require opening the chest, because we are creating ablation lines in the back of the heart. So it's extremely rare, but it's possible that the unexpected bleeding may occur. The benefits of the conversion is that it is less invasive than the open heart surgery, the full maze procedure. The other benefit is that the left atrial appendage is excluded, which cannot be done by the catheter ablation. And then now the success of the conversion being a hybrid procedure is in between that of the catheter ablation and then the maze procedure. As Dr. Warrier described before, the success of the catheter ablation is anywhere from 20% from a single ablation to 45% after multiple ablation. And this is the success of 5 years. For the maze procedure, the traditional full maze procedure is about 90%. So a trade-off between maximally invasive 90% versus 20 to 45% success rate with the catheter ablation. The conversion success rate is about 70%. The recovery is quite quick. The hospital stays about 2 to 3 days, and the recovery takes about 2 weeks or so, since the only incision is the 1 inch incision below the breastbone. Next slide. So here we have a short video of the conversion procedure that we can all watch together. So this 1 inch incision is made below the breastbone, and a sheath is passed through the incision into the pericardial sac, which is the sac covering the heart. And through this sheath, a probe is placed through the sheath. The probe is connected to a machine. So you're looking at the back of the left atrium on the right of the screen. Now we're looking at that's the pulmonary vein that drains into the left atrium. That's the right 2 veins, and these are the left 2 pulmonary veins. So in total, 4 pulmonary veins draining blood into the left atrium. So after looking at the back of the heart, the next part is actually creating the ablation lines with a probe. So this probe is now passed through the sheath, and then now this probe is now creating 1 ablation line. It takes about 90 seconds to create the ablation line. So the ablation line is created by radio frequency ablation. So 1 line is completed. Now the probe is moved on, and then multiple parallel lines are created on the back of the heart. So essentially, the back of the left atrium is burned with these multiple ablation lines. So the left atrium is fairly thick, so it's very difficult to create any hole in the back of the left atrium. So the bleeding risk is very low. So in summary, the conversion procedure is a hybrid procedure used to treat atrial fibrillation. It is less invasive than the traditional full maze procedure, which requires opening the chest and then going onto the Holter machine. The success of the conversion is between that of the catheter ablation, which is 20 to 45%, and then the maximum success rate by the maze procedure is about 90%. So 70% is what's quoted as a success rate for conversion. And by success rate, we mean what is the freedom from atrial fibrillation. So in selected patients, this conversion procedure is a first good option to treat AFib. In other circumstances, catheter ablation is the first option. With regards to a full MACE procedure, sometimes patients need open heart surgery, let's say to replace or repair the heart valve. In those cases, the full MACE procedure is done at the same time as the open heart surgery. But for isolated atrial fibrillation, conversion procedure is a good option. Well, thank you for joining us for this presentation on discussing the conversion procedure.
Thank you again from my end as well. Thank you, Dr. Lam, and thank you to Memorial Care for having us for this talk. Again, as Dr. Lam had mentioned, this is a great option for certain patients as a first-line treatment for their atrial arrhythmia, and I think it's very important for us to see a heart rhythm specialist to evaluate the best course of action in terms of therapies.
Thank you, Dr. Lam and Dr. Warrior. We appreciate your time and clinical expertise on this important health topic. And thank you everyone who joined us to watch this virtual presentation.